So this is the second half of the X-ray interpretation talk. So the first case is a 66-year-old woman. She's got a long history of COPD. She's got a little bit of a low-grade temperature, and she's feeling kind of poorly. O2 sat is down. You just decide to get a chest X-ray. Chest X-ray shows a pretty dramatic infiltrate here. This is one of those things that is very common, is that when you really have a good infiltrate, when you really have pneumonia, it's usually going to show up. Lots of times people want to take a relatively normal chest X-ray and almost overinterpret it. They see this infiltrate, imaginary infiltrate, if you will, here. Usually this is either breast tissue, normal markings, and infiltrate is usually going to show up pretty obviously. If it doesn't, then I think it's reasonable to go based on clinical grounds and wait for the radiologist's interpretation. Next case is a 15-year-old boy. He's playing football. Mom thinks he's favoring his arm a little bit, and on further questioning he says, "Oh yeah, I got tackled and I felt a pop near my left shoulder." You X-ray, and this is what you see. You see a crack through the clavicle there. It's essentially non-displaced. It is away from that distal third. Generally, these are pretty easy to treat. You put them in a sling. You can have them follow up with orthopedics if you want to. Otherwise, you're just going to restrict their activity for 4 to 6 weeks until they show good callus and good healing of that clavicle. This case is very different. This is a distal third fracture. It's kind of out of place. So that patient is going to need a more urgent evaluation by orthopedics, just because they might need to have that repaired. This is an example of a tenting X-ray, kind of sticking up almost through the skin. This is an X-ray that shows a fracture that probably should be evaluated fairly urgently by orthopedics. So you got an 18-month-old, they fall, they hit their head, no loss of consciousness, they come up screaming. Their Glasgow Coma Scale is now 15. Imaging options. A lot of people want to image this kid. There's probably not any reason to do so, however. If you've got a normal neurologic exam at this point, there was no loss of consciousness, imaging is not going to add anything to you. So yes, the imaging options are to do a CAT scan or to do nothing. I think that it's especially important to remember that in an 18-month-old, you're probably going to have to sedate this kid to get an adequate CAT scan, depending on the kid. So most people would go ahead and not image this kid. Skull X-rays are not going to be helpful in any way, so generally off. 52-year-old woman. She's got right lower quadrant pain. She's got a little bit of a low-grade fever. She had menopause 2 years ago. What's on your differential? So always remember both gynecologic and intra-abdominal possible causes of abdominal pain. It's possible that she has an ovarian cyst. It's possible that she has an ovarian torsion, which is usually related to an ovarian cancer, which is dropped down and twisted. It's also possible that she's got an appendicitis. It's possible that she's got diverticulitis. Diverticulitis is more common on the left side, but probably about 10 to 15% of the cases of diverticulitis that you see will be on the right-hand side. It's possible that she has cancer. There's any number of different possibilities. In general, if the abdominal discomfort is substantial enough, the patient is going to get a CAT scan. Some people will try to do ultrasounds for these kinds of things. For the practical purposes, in general, most emergency rooms have 24-hour coverage for CAT scan now. Ultrasound requires calling in an ultrasound tech. And then the sensitivity is probably slightly better for CAT scan. So if you look at the ACR appropriateness criteria, it's going to suggest a CAT scan. In this case, she had an abdominal series. Now, when would you do an abdominal series? Well, an abdominal series for me is reserved for a situation in which you really don't have the option to do a CAT scan. Abdominal series usually includes 3 films: flat plate, upright, and a AP chest. Well, actually, usually it's a PHS, sorry. And in fact, what you're looking for are predominantly 2 things on the upright, and that is the presence of intra-abdominal diaphragmatic air. In the abdominal cavity, there should not be any air. If you've got air, that means there's a perforated viscus. If there's a perforated viscus, that patient probably needs to go to the operating room. The other possibility is when you're looking at the upright, you can see that there is an obstruction. Now, in this particular case, the obstruction is predominantly in the colon, and you can see the air fluid levels pretty clearly. Flat line on the bottom, which is where the air is floating on some fluid, kind of a bubble on top of a fluid. A regular bubble is going to be round. Bubble on top of a fluid is going to be flat, so you have air fluid levels. In the colon, air fluid levels might be considered normal. There's still going to be a sign of obstruction. Down here you can see there's a lot of stool right in the rectal area. Dilated colon on that left side, air fluid levels on the right side. So probably this patient needs, enemas or something to clear the colon. If you see air fluid levels in the small intestine, then that is a bit more concerning, because a small bowel obstruction usually will not clear just with laxatives or enemas. They usually need bowel rest. Another convention to be aware of is looking to see this arrow means that it's an upright. Flat plate does not have that, and so that way we can tell that these are air fluid levels on the upright. Flat plate, or KUB, kidney, ureters, bladder, is the way it's usually referred to, although really it's just a flat plate of the abdomen. That's the same film. If you look at this CAT scan, you can actually see the appendix is enlarged and inflamed. This is something that usually the radiologist will have interpreted. And this is actually a distended, enlarged appendix as well on the coronal view. This is what appendicitis usually looks like on ultrasound. You can see that there's a distended appendix here. Fecalith is a small amount of stool that's basically calcified and hardened, and you can see that that is oftentimes associated with appendicitis, although you can have a fecalith without appendicitis. So there's a 55-year-old woman. She's got knee pain. It's interfering with her function. And so you're going to get some kind of imaging of her knees. The big take home here is that make sure if you do get imaging, in general, you want this to be a standing image. You can see that there is increased whiteness here. That's a sign of arthritis. Narrowing of this joint space. On this side, you can see it's basically gone. That's also a sign of the cartilage being gone and arthritic changes. There's a little bit of whitening here, and that's a sign that there probably is a little bit of arthritis developing. Other views may be needed, but in general, if you've got a really bad osteoarthritic knee, you're going to be able to see it on an upright PA. 30-year-old woman, basically she was dancing. What happened was there was a lateral force applied to the foot, basically pushing in from the side while the ankle was in a flexed position, toes pointed to the floor with the heel off the ground. And in that situation, she developed a fracture right here at that base of that fifth metatarsal. That's a particularly important fracture to find, just because, like the navicular or scaphoid in the hand, the Jones fracture in the foot is very likely to go non-union if it is not picked up. The way it's usually treated is cast or removable boot with limited or no weight bearing for 6 to 8 weeks. And then after there's signs of healing on x-ray, then progressive weight bearing. 40-year-old woman, she can't fully extend her finger, no real history of trauma. She comes in, you look at her finger, she's basically unable to extend that DIP joint, and you can passively move it without any difficulty at all. In fact, what you need to do, you need to get it out to full extension and immobilize it. There is something called a stack splint that is probably the best way to do this. Otherwise, you can use a Lumafoam. If you have nothing else, popsicle stick and some gauze and tape will actually get it out to extension. It needs to be immobilized for probably 6 to 8 weeks. And in general, they'll usually heal during that time. If they're moved at all during that time, lots of times they'll interfere with the tendon repair, and so it won't heal. Sometimes they do need surgery. It's completely appropriate to send them to orthopedics, although if you've got the stack splint and you can keep them in good extension, it's probably not absolutely essential. It's a 26-year-old woman. She fell down while she was skiing. Her right elbow was very painful, very swollen, and you think, oh, this is probably broken. You look at her x-ray and you think, it looks okay. But on further analysis, you need to look beyond the bones. So here's the bones. So this is the radius right here. The ulnar is out here. This joint space actually looks pretty good. The things you need to learn to look at on an elbow x-ray are the fat pads. This is the posterior fat pad, this dark spot back here. This is the anterior fat pad. The anterior fat pad, in this case, should be flat along the side of the distal humerus. It's not. It basically is kind of sticking out, kind of in the shape of when you were 7 or 8 years old and you tried to draw the sail of a boat. That's how you drew it, was this straight up line and then this little triangle off to the side of it. You can see that. That's called a sail sign. That's usually a sign of a fractured distal radius, and if we really stare at it, we can almost see that there might be a little fracture in that distal radius, but the sail sign really tips us off. This person needs to be put in a sling and then follow up with orthopedics. 44-year-old woman, she falls down the 6 stairs on her buttocks. There's a lot of pain over her coccyx. She wants to know if her coccyx is broken. She wants to know if she can have an x-ray. The problem is that we get our lumbosacral films. We see that there's maybe a little bit of an anterior listhesis here, where the movement of the bone is anterior. But if we look at the coccyx, we can see, well, is that a crack? Is that not a crack? A lot of people don't fuse well. Sometimes there is a crack, but then you ask yourself, well, if there's a crack, how am I going to treat it? And the basic answer to that is pain medication for 3 or 4 weeks, ice, try not to sit on it, and try not to worsen it. The only way to really be sure if somebody has an acute coccyx fracture is to do a rectal exam and elicit crepitus by touching the coccyx. Rarely is that necessary, because rarely will it change your treatment. You're just going to use pain medicine and try to keep them comfortable until it heals up on its own. Next film is of a 55-year-old veterinarian. He fell against the stall 4 days ago. He's been walking with a limp ever since, and he feels like it's getting more swollen, more painful. And if we look at it, we can see that this ankle looks not terrible, but with an obvious fracture out here in the fibula. The mortise seems to still basically be intact. The joint spaces are not widened. This is how somebody can go with a fibular fracture for several days and not need intervention for it. it usually eventually is painful enough and problematic enough that they do seek care. George H.W. Bush's wife, Barbara, actually had a fracture like this a number of years ago and had walked on it for a week or so before she went in to have it taken care of. So, fortunately, a broken leg to a large animal vet, they worry about having to put the large animal down. In this case, we were able to save the veterinarian. We basically put him in a non-weight bearing status until he saw orthopedics. If you have one of those large gray boots, you're welcome to put it on them, but basically you can wrap them up in an ace wrap. If you have orthoglass and you want to put a posterior splint on, that's completely fine too. But basically you just need to get them wrapped up, get them evaluated by ortho. They'll usually keep them in some kind of immobilization for a month or so, x-ray it to make sure it's healed. This fracture especially needs to go to ortho because it's not that far from the joint space. Any fracture that's near the joint space obviously is a bit more concerning. I think there'd be some concern for development of arthritis here in this joint. So any other thoughts that you've got, please add them to the discussion of this video. Alternatively, if you're in a course that I'm teaching, feel free to post to the discussion board for that Blackboard. This concludes the X-ray talk.